Well, Dr. Hosten, I would like to thank you for joining the Pemberton Diabetic Group of the St. David's branch of the Grenada Diabetes Association today. For those of you who are viewing, Dr. Terron Hosten is the chair of the Department of General Surgery in Grenada, and he is the medical director for Fit for Life Medical Services. And I asked him to join us today because he has done hundreds of amputations because it is necessary to save a diabetic patient's life. And I just want to be able to ask him some questions about that. And hopefully we would know how to avoid it happening to us. So doctor, welcome and thanks for being with us this evening.
Good afternoon, Ms. Douglas. Thanks for having me here on the program. Thank you.
You have a big task and it's tough because you have to make this decision of doing amputations. Can you tell us what signs do you see that will make you have to make that tough decision that something needs to be amputated? Can you walk us through that process?
Right. So usually in the surgical department, we tend to see the end product of patients who would have failed to treat and manage the disease properly. And usually when we get to see such patients, it's way beyond salvation of a limb or salvaging the foot, the toe, etc. So most of what we see, we have no choice but to ultimately save a life by removing the limb or removing a part of the limb. So I think that is what we've been seeing. Once you have tissue that is dead, you cannot revive it. And that's when I speak of end product, we tend to see that. So, and we basically believe in a nutshell that the majority of the times that we see that, it's due to the fact that the disease was not managed properly, regardless at whatever level it was not managed properly. So that's why sometimes it comes down to that we have no choice. If there was a choice, then we offer it. But based upon the circumstances in which the patient arrives, then we have no choice but to go ahead and do amputation.
You were kind enough to visit us at the Pemberton Diabetic Group to give a talk. And one of the things that you said in your presentation was discoloration, oozing. Can you explain that for the benefit of those who were not there? What are some of the telltale signs that there is a lack of circulation causing this kind of discoloration?
Right. So maybe I should just firstly speak of the types of gangrene that we see, and so it kind of gives a broader explanation to discoloration and other signs that we may see. So there is the ischemic gangrene, ischemic meaning lack of blood supply. That's the one that we see where the foot gradually becomes darkened, or the distal limb becomes darkened, and eventually it sort of shrivels up, dries up, because there has been a gradual decrease in blood circulation. Most of this we attribute to the buildup of plaque over time in the vessels. You see that commonly in patients with what we call peripheral artery disease, where the arteries, as they leave the heart and they go further away, they become narrower and narrower. So we tend to see a lot of these patients with peripheral artery disease suffering from that ischemic gangrene. So that's the one that may not have a foul odor or so, but you notice gradually that the limb is becoming darker and darker. And that's where I guess the discoloration, the whole issue of discoloration comes into effect.
Mhm.
And eventually we would, once the tissue is dead, we have no choice but to remove the part that's dead. And we leave the part that is alive so that it can attempt to heal,
Mhm.
right? So there are certain studies that would assist us in making such a decision, such as ultrasound of the arteries, we call them Doppler, to find out where is it, at which point the circulation stops or is significantly reduced that we would not get any healing. And we will discuss that with the patient and they would understand that even if the foot seemingly looks okay, if there is no blood circulation, there wouldn't be healing.
Mhm.
So that type of gangrene is called the ischemic type.
Mhm.
Now you also have the wet gangrene. That's the one. So that gangrene too, we call it dry gangrene because it's like it dries, it shrivels up, it mummifies.
That's the ischemic one.
That's the ischemic one.
Mhm.
Then you have the wet gangrene. That's when now you have bacterial infection. So the bacteria, the bill, you see that a lot in most diabetic patients who come in with gangrene. You tend to see a wet gangrene because one, if the sugar is not controlled properly, and remember I made mention of poor management of the disease. If the sugar is not controlled properly, then you'll have more sugars circulating in blood. Sugar, as we know, is also food for bacteria, right? And with increased circulation of sugar in blood, we would also have poor healing capabilities, right? The immune system is weaker, so there is more chances of the bacteria building up to a point where it beats your immune system. And when bacteria destroys, it will leave a lot of secretion and stuff like that. And you get that wet gangrene.
Does it look like pus or water
So
or
you can
jelly?
you would have dead tissue, you would have that pus. You can even have an offensive smell, especially when you have certain bacteria that produces certain offensive secretions.
Mhm.
And you would notice a lot of draining and so from the limb. So
Mhm.
that's a wet gangrene, and we see that primarily in these uncontrolled diabetic patients. So once again, with lack of management, we see these things. Cases like that, we may opt for debriding of the wound, where we clean up the wound and we may be able to salvage the limb.
Okay.
But I would ask you, if the entire limb is destroyed, can we salvage it? The answer is no. So that's when we speak of saving a life by removing the limb. You remove the limb because imagine you lost the battle in the leg. That battle is going to be carried to the central part of the body, and that's when we talk of sepsis. When you become septic, and eventually after sepsis, once it's untreated, you will die.
Mhm.
Right? It sounds harsh, but that's objective reality.
So you talk about
So,
the ischemic and you talk about the wet gangrene. Is there
right,
another one?
correct. So then you have that dreaded one we call the gas gangrene. So it's also similar to the wet, except that usually the bacteria that you find or the microbes that you find in that type of gangrene tend to produce a lot of gases, and they tend to operate in the absence of oxygen. So they're called like anaerobes. There are very classic species of these that we call the Clostridium species. They're very known for destroying tissue and producing this offensive gas and offensive secretion.
Mm.
So a wet gangrene can easily, with the presence of that Clostridium species as they multiply, you know, these bacteria, they would proliferate, they would multiply and make generations upon generations in 30 minutes.
Mm.
So, and they're very aggressive. So they can get to a point where they have grown to the point where they can destroy tissue at a rate unimaginable. One of the things that you would notice with such gangrene is that you would feel like a bubble wrap sensation if you were to press on the limb. You would feel like air pockets under the skin. This one kills in a matter of hours, and it moves very fast. So a gas gangrene that started this morning down in the foot, for example, by evening, it could be all of the leg and even to the thigh. And failure to make a decision in the moment can determine whether it continues. And you remember what I just said.
Yes.
And it continues upwards until you become septic and you die.
Mm.
Right? If left untreated. So this goes back to your first question about, you know, is there, what are the options? But when you have cases like that and the condition in which they arrive, because we have cases where they come when it's already up the leg because they're a bit hesitant, you know, and we have no choice but to salvage life over them. Right? So a lot, as I goes back to the same thing that I mentioned, management of the disorder to prevent the onset of these things.
One question, the gas gangrene does that develop because the wet one was left unattended or the ischemic one was left unattended, or is it something separate but still as a result of uncontrolled diabetes?
So I believe, based upon what we know, that they can happen separately, but they can also be a continuation of each other. I'll tell you an example. If you do not have the anaerobic bacteria, the ones that produce the gases, the offensive gases, like the species I told you about, it might be very difficult for the development of a gas gangrene, right? But if they were present in small amounts and they were given the opportunity to multiply, as we spoke about that a while ago, then you can see the transition from a wet to a gas. If you have an ischemic gangrene, a dry gangrene, and somehow ischemic, remember, we didn't speak of bacteria there. We spoke of the body just reducing its blood supply.
Right.
But you happen to have bacteria proliferating, growing, and infecting that ischemic tissue, then we could probably shift from dry to wet. And if some of them happen to be Clostridium species, then we can move from wet to gas. So you see, they could be presented as individual, but they could go up along that scale.
There are some patients or family members that may see loved ones and the skin color of their toes and their legs and feet are changing to a darker color, and they may brush it off as, oh, that's hereditary. That's how a relative who was that age, that was what was happening to them. Some believe that someone may have done something to them in terms of witchcraft, but what advice would you have for someone who knows that they've been diagnosed as a diabetic, or maybe they haven't, they have other symptoms, but there's a distinct change in the color for our complexion, when I say our, of African descent, and they're choosing to not see a doctor or to refuse amputation, what could happen?
Well, I have heard of certain cases like that. In fact, I've had patients come to me and saying, Doc, you know, they gave me that foot. I don't know if you've heard that one.
Sure.
Right. So culturally we're bound to these kind of things. We would hear them ever so often. But really and truly, we need to get past that, because I think one of the main problems is that patients who are deeply rooted in that, they tend to go into denial. And I think denial is one of the issues that we have. Reason for that being, if you're thinking, well, they gave you that foot, then, you know, they gave you that foot, that's how it is. So then you would see it as, it's not that it's infected. It's not, it's just that they gave you that foot, you know, it's a spiritual thing, I guess.
Yeah.
So you would see it in that light. So that's naturally going into denial. You would resist the chance of being treated, right? Since you're bound to thinking that way.
Right.
Well, I think a lot has to do with denial. And then when reality hits, sometimes that's when, as I spoke of, it's when it's far gone, and then,
You
you
have
know.
sepsis and then ultimately death.
Right, good. Yeah, there are times when we've had patients who they need time to make up their mind.
Sure. Because it's
And
traumatic. It's traumatic.
we will always advise them to speak with someone, but try to be as quick as they can, because the clock is running out against them. You know, some of them, they would just blatantly outright opt out of treatment, and we have no choice, our hands are tied. But then you find at the end, when the objective reality kicks in, they come back. But sometimes it's too late.
Well, Dr. Hosten, I thank you so much for being with us to shed some light on what leads up to that decision of amputation. And you shared with us is ischemic, you've got the wet gangrene, and then you've got the gas gangrene. And if these things are not removed after you've done the Doppler, after you've done the examination, and you found that there's a lack of circulation, infection, or if it's gas gangrene, the patient's life is at risk, and making that decision is something to save their life. So we thank you for providing such a thorough explanation with us today.
Thank you.